Thank you all very much for having me tonight. I'm really honored to be part of this program, especially when I found out that it's the first inaugural program. Hopefully I can be back for the second and third and many more after that. So I'm a pediatric otolaryngologist. I have a special interest in hearing loss and genetic hearing loss. And I've been working in this field for over 10 years now, and I've really been able to see a dramatic change in our evaluation of children with hearing loss in the genomic era. So I'd like to go through that with you today. So first of all, I have no conflicts of interest. So when I think about any sort of talk that I'm invited to, I have a pretty short attention span and can't remember too much. So I like to think of some take-home points for you to remember. So first of all, I'd like to say that genetic testing for deafness, it provides valuable information for you and your patients. And secondly, it's the single test with the highest diagnostic yield for evaluation of children with hearing loss. And third, it has become the standard of care for children with hearing loss. And hopefully by the end of this presentation, I will have convinced you of these 3 points. So I'd also like to start by talking about 3 patients. All 3 of these patients are planning for a cochlear implant. The first patient is a 6-month-old female. She has congenital profound hearing loss, otherwise normal physical exam, and no family history of hearing loss. The second is an 11-month-old male. He also has congenital profound hearing loss and no other abnormalities on physical exam. He has an uncle with mild to moderate hearing loss. And the third is a 14-year-old female with a postlingual progressive downsloping hearing loss, no other abnormalities on physical exam, and no family history of hearing loss. So I'll show you by the end of this talk how genetic testing and genetic evaluation altered the clinical care of these 3 patients. So an overview of the talk, I'll talk about what is genetic testing for deafness, why should we perform genetic testing, who should receive this testing, and how should this testing be performed. So what is genetic testing for deafness? First of all, to understand that, you need to understand the causes of congenital hearing loss, which occurs in 1 in 500 children. Overall, about 65% or 2/3 is due to a genetic cause. The remainder are due to ototoxicity and trauma, congenital CMV, and anatomic issues. As I said, genetic causes are 2/3 of the etiologies, and non-syndromic hearing loss, dominant and recessive, makes up about 50% of this. So when you look more specifically at genetic hearing loss, syndromic causes are about 30% of genetic hearing loss. And this is syndromes such as Usher syndrome, Pender syndrome, Waardenburg syndrome, syndromes that we all know. And there's over 400 reported syndromic forms of hearing loss. When you look at non-syndromic forms of hearing loss or hearing loss not associated with other clinical features, this makes up about 70%. And this can be inherited in recessive, dominant, mitochondrial, or X-linked inheritance fashion. And we know that hearing loss is extremely genetically heterogeneous. To date, there's 122 total non-syndromic deafness-causing genes and more than 8,000 known mutations. So another way to look at that is all these 122 non-syndromic hearing loss genes. There's 48 of what we call non-syndromic mimic hearing loss genes. And what I mean by this is these are genes that cause syndromic forms of hearing loss that in a newborn will look like non-syndromic hearing loss. So there are no other features such as blindness in the case of Usher syndrome or thyroid goiter in the case of Pendred syndrome. And then there's all different types of genetic mutations. There's missense variants, nonsense variants, splice sites, small insertions and deletions, as well as copy number variation. In total, there's 1.2 million base pairs of DNA that can be affected. And as I said, 8,000 reported deafness-causing mutations. This makes genetic diagnosis for hearing loss extremely difficult, but it's also what makes it so interesting for me to study. So when you look at 1,000 patients with genetic hearing loss, what you see is that it's extremely genetically heterogeneous. So for a long time, we thought that GJB2 caused up to half of genetic hearing loss, but we found over time that this is only true in very certain populations, which I'll talk about later. Overall, in these 1,000 patients in this study of ours, there were 79 different genes. GJB2 made up 20%, stereosilin was second most common with 14%, and then SLC26A4 or pendrid was number 3. So there clearly is extreme genetic heterogeneity. And what makes this even more difficult is the heterogeneity among different ethnicities. So you can see in this study of ours from 2016, when you look at Caucasian individuals, the contribution of GJB2, it's quite common. When you compare that to African Americans, it's much less common. And in Asians, GJB2 hearing loss is far more common. And so there's, in addition to genetic heterogeneity, there is also ethnic heterogeneity that makes this even more difficult and interesting to study. So how do we do this testing? Well, the only way to screen all these different genes and mutations is using comprehensive genetic testing. Over the past 10 years, these genetic testing platforms have evolved and really become standard of care. There's many different testing platforms in the United States. This is the testing platform that I work to develop called Otoscope Genetic Testing. There's several others that are available as well. All of these tests use new DNA sequencing techniques called massively parallel sequencing to sequence all the non-syndromic hearing loss genes and many syndromic hearing loss genes at the same time. And this, for the first time, truly allows for comprehensive genetic testing for deafness. So why do we perform this genetic testing for deafness? Well, the short answer to that is that it really is the single most effective test that you can order for children. And we know this through several studies. So overall, the diagnostic rate, that means the chance that you will come up with a diagnosis for genetic testing, is approximately 41% across these studies. When you compare that to a CT scan, has a diagnostic rate about 30%, and an MRI has about 26%. All the other types of tests like urinalysis and thyroid ultrasound, those contribute just a small number to the diagnosis. Genetic testing for hearing loss is also extremely important because it provides important information for families. So it gives prognostic information. So families want to know whether the hearing loss is going to stay the same or whether it's going to get worse. And genetic testing can help provide that information. Families also want to know about recurrence risk. So that's the risk that if they have another child, whether they will be affected with hearing loss as well. And if we have the genetic diagnosis, then we can answer that question. In addition, once that child is having children of their own, we know what the chance is that their child will be affected by hearing loss. And then maybe most importantly that we're finding more recently is that this sort of testing evaluates for syndromic causes of hearing loss. I don't think anyone realized how common syndromic forms of hearing loss like Usher syndrome, Pendrid syndrome, and Waardenburg syndrome were until we started performing genetic testing for these forms of hearing loss on all babies. We now know that up to 23% of diagnoses in otherwise healthy appearing babies are actually syndromic forms of hearing loss. And this is a very important piece of information for families to understand. So another reason why to perform genetic testing for deafness, well, because there's consensus guidelines saying that we should be doing this. So several years ago, the International Pediatric Otolaryngology Group provided consensus recommendations that genetic testing should be used in evaluation of hearing loss. In addition, the American College of Medical Genetics and Genomics also endorses genetic testing for diagnosis and evaluation of hearing loss. So who do we perform this testing on and how do we do it? when we look at more than 1,000 patients with hearing loss, as I told you, the overall diagnostic rate is about 40%. But this varies based on clinical characteristics. So if you look at those with a family history of hearing loss that's autosomal dominant, you're more likely to uncover a genetic cause. If you look at children that have a congenital form of hearing loss since birth, you're also more likely to uncover a genetic cause. And if you look at symmetric hearing loss that affects both ears, you're far more likely to come up with a genetic diagnosis compared to unilateral hearing loss. The positive diagnostic rate for unilateral hearing loss is very low, we think, because this is most commonly due to temporal bone abnormalities and cochleovestibular abnormalities. And we do not yet have a great understanding of the genetic contribution to these forms of hearing loss. So if a child presents to your clinic with a congenital profound sensory neural hearing loss with an otherwise normal physical examination, I tell them that we have about a 50% chance of uncovering the cause using genetic testing for hearing loss. So this is really fantastic to be able to obtain this with one single test. So this is the protocol that I use in my clinic and is recommended through those consensus guidelines that I talked about. If there is a child with suspected non-syndromic sensory neural hearing loss that is bilateral, then the first test that I order is comprehensive genetic testing. If this is positive, then we move forward with treatment. If this is negative, then I obtain imaging and further workup. Based on the age of the patient, I'll tell you, and I'm happy to answer more questions later, but at our institution, I typically perform an MRI in younger children because I feel like this gives the most amount of information. And then depending on whether we're moving forward with a cochlear implant or not, or the findings on an MRI, I may get a CT scan as well. In cases of unilateral hearing loss, we proceed directly with imaging and further workup. We can consider genetic testing, but as I told you, the diagnostic rate for unilateral hearing loss is quite low. So as I said, imaging is preferred for unilateral hearing loss. So how do you perform genetic testing? Well, and this is what I do. I take a detailed history, including birth history, as well as stay in the NICU, a family history, social history, and then past medical history, including things like aminoglycoside antibiotics exposure and infections. I perform a physical examination to evaluate for syndromic causes of hearing loss. I look for ear pits and tags, cleft lip and palate, or any vision loss that could be a key to the diagnosis. And then perform audiometric testing, which of course is crucial to the diagnosis. And then order genetic testing. So depending on your hospital and how familiar you are with genetic testing, you can order this on your own or refer to another provider. I typically order the genetic testing on my own because of my background and interpret that myself. I know that many people refer to a geneticist or a genetic counselor who then orders the genetic testing, and this is perfectly reasonable. So I'd like to talk about these three patients again that I started the talk with. The first patient was a 6-month-old female, and that genetic testing revealed 2 mutations in the gene cadherin23, and this provided a diagnosis of Usher syndrome type 1. This is really one of the most devastating diagnoses that you can provide. And really, before we started performing genetic testing on young children, we did not make this diagnosis until much later in life. Actually, in 2010, when we performed our first study on comprehensive genetic testing for hearing loss, one of those children we diagnosed with Usher syndrome type 1. And I'll never forget that the mother was very devastated at first to discover that her child would not only have hearing loss, but would also become blind. But we also had to convince the ophthalmologist to see the child who was at that point just about a year old, and they had never evaluated a child that young for retinitis pigmentosa. The mom, after a while, was very grateful to be given this diagnosis of Usher syndrome, because there is some data that if you wear sunglasses and take vitamin A, you can prevent the onset of the retinitis pigmentosa. The second patient is an 11-month-old male, and this genetic diagnosis revealed 2 mutations in KCNQ1. KCNQ1 causes Jervell and Lang-Nielsen syndrome, or long QT syndrome. These children are exquisitely sensitive to changes in their QT interval, and this can lead to sudden death. This can occur sporadically, but it can also occur during surgery. So this is a way that really genetic testing can save the life of your patient if you obtain it. It's also the reason that we will consider obtaining an EKG in children that have congenital profound hearing loss. And the third patient is a 14-year-old female. She had 2 mutations in the gene TMPRSS3. And I and others have shown that mutations in this gene may increase your chance of poor performance with a cochlear implant. I'll talk more about this in a minute. This is a controversial research finding. It's still, there's still more research that needs to be done on this, but it may be something important that we're telling our patients in the future. And so I hope I've shown you with these 3 patients that genetic testing for hearing loss directly affects your patient care. So to talk about future directions, as I mentioned, a big question that I'm interested in and others are, can we predict cochlear implant outcomes with genetics? This schematic of the auditory system shows the hair cell, the synapse, the auditory nerve, and the brainstem. And as you all know, the cochlear implant electrode bypasses the inner hair cell and the synapse to directly stimulate the auditory nerve. Many people have hypothesized that those with mutations in the inner hair cell or the synapse will have a good outcome with a cochlear implant, whereas those with mutations in the nerve will have a poor outcome. So far, the data seems to show that there are very good outcomes reported for 8 different hearing loss genes, and more poor outcomes reported for 6 genes, and unclear outcomes reported for 3 different genes. This is still exploratory research, and I'm very interested to move this forward. I've worked in this area for several years, and I think the results are very exciting. Another future goal is to improve newborn hearing screening. As we heard in the last lecture, newborn hearing screening is very important, but there are ways that it could be improved. So current newborn hearing screening evaluates all newborns who obtain physiologic screening, like the auditory brainstem response, or OAE. And if they fail this, then we pursue this different testing. Our proposal in a recent paper was to perform comprehensive newborn hearing screening where all newborns undergo physiologic screening, genetic screening, and congenital CMV screening. This is already happening in China, and there's one province in Canada where they're using this as well. We think that this would help because it would provide etiologic or diagnostic information to patients and family. It would reduce time to diagnosis, and it could possibly reduce those who are lost to follow-up because we perform all testing at the same time. And then very importantly, there's been huge advances in gene therapy for hearing loss through multiple different approaches. There's been multiple different gene therapies that have had wonderful results in mice. There are several clinical trials that will be starting in humans soon. I know in Boston alone, there's several companies that are very active in gene therapy for hearing loss. But we all have to remember that gene therapy, it requires a genetic diagnosis. So until you have a genetic diagnosis, you can't pursue a gene therapy. And so this makes it incredibly important. And then the last thing I'll say, for future direction is I'm very interested in different ethnicities. So you can see in this study, we only had 44 patients of Latino or Hispanic origin. And my question is, what about Mexico? You know, we need to learn more about different countries and the genetic contribution to hearing loss in these countries, because this really is precision tailored medicine when we start talking about gene therapy, and we need more information about different countries. So just to summarize, the three most important points from the talk, if you remember anything, are that genetic testing for deafness provides valuable information for you and your patients. It's the single test with the highest diagnostic yield, and it's the standard of care for children with hearing loss. So I'd like to thank you. This is a view of Boston Harbor, and I'm the director of the Translational Hearing Genomics Lab, and these are all the wonderful colleagues that I work with at Boston Children's Hospital and Harvard Medical School. Thank you very much for your time.